Well, hi, and welcome to this exciting webinar. Well, I hope it will be exciting. My name is Alain Luciani, and I welcome you to this webinar dedicated to spectral imaging in oncology and focused on lesion detection and characterization. Now, I'm, as I said, Alain Luciani. I'm a radiologist in Henri Mondor Hospital that's close to Paris, and I'm very happy to be able to discuss with you and hear your questions. And first, to start up with, maybe we could start up with detailing a little bit what potentials of spectral imagings are actually. And to deal that and to start up with, I have one keyword, is that we have to keep it simple. If we want to use spectral imaging in clinical practice, well, we have to show, or we have to demonstrate first that it's kind of simple. And the first thing is to demonstrate is to understand the basic principles underlying spectral imaging. And to that, I will only show three technical slides. That's the only slides a little bit complicated, and the rest should be very easy and straightforward. So on we go, and to start up with, let's discuss the difference in physical principles between what I could say is a conventional CT system versus a spectral CT system. Now, with the conventional CT system, we are dealing with polychromatic spectra of energy. That is, the X-ray beam has different energy levels. It's up to 120 kVp, which is the peak of the energy of the photons. But actually, the spectra is, as you know, polychromatic. What that means is the materials analysis is based on material densities, Hounsfield units, which only partially depend on the material composition. And actually, materials could have the same attenuation, although they share different atomic numbers. Now, on the opposite, spectral CT systems are different. Now, with spectral CT system, the materials analysis is reflected by atomic numbers. And the analysis is based on the attenuation spectra, which is observed at two different energy levels, whether they are provided by a dual energy single source CT system, such as that with General Electric systems, or with dual tube eventually, or whatever system you want. The only thing is you have to have two energy spectra, and this will provide especially sensitive analysis with materials with high atomic number, because you're optimizing photoelectric effect. So, first slide, physical principles. We are using two energy spectra, and we are reconstructing the images based on those two energy spectra. And how do we do that? Well, if we look at the way we deal with materials, and we say if we had two materials of atomic number Z0 and Z1 that were imaged at two different energy levels, namely 80 kVp and 140 kVp. So using two polychromatic spectra and underlying the attenuation of that materials on those two different energy levels. Well, what you can see is that material Z1 does not behave the same way as material Z0 when it's exposed to either 80 kVp or 140 kVp. There's difference in attenuation levels. So the attenuation profile of those two materials is actually different when they are imaged at two different energy levels. And that's the second important point of using spectral imaging, is that you can decompose materials based on materials for which you know the exact attenuation profile. For instance, look at that slide. If we look at those four different tubes, and look at, for example, tube number 2. Now, if we want to analyze tube number 2, if we want to define which materials are composed within tube number 2, well, we could imagine that tube number 2 is actually a composite of two materials, material A and material B. And if we know the attenuation profile of material A and material B exposed to different energy levels, well, we can reconstruct actually the atomic composition of materials number 2 as a composition of material A and material B. Why is that? Well, because actually material A and material B do not have exactly the same attenuation profile. And actually we have maximum attenuation for material B very close to 190 keV, which is what the so-called K edge of the material. And we have a K edge of that material, so the maximum attenuation around 90 keV at material A. And if we look at that material too, well, look, here it's imaged at 100 kVp, here it's imaged at 200 kVp. And look at the attenuation, how that rises here at the 200 kVp. What does that mean? That means that in material 2, there is more of a material showing high attenuation at 190 keV than a material A. And this is the way we can actually, and this is the third important point of spectral imaging, which can actually reconstruct the images of tube number 2 as a composition of material A and material B. And if you know the attenuation profile of a specific material and you put it in the system, well, then you're able to reconstruct whatever tissue you want made as a composition of those two different components. And if we look at the K edges of the different components that we could image in clinical practice, well, there we go. Iodine has a high K edge as opposed to, for example, water. So the idea here is that you can actually decompose a material based on using two different materials of different components and showing different attenuation values. So to sum that up in a single slide so that we make it simple and easy to understand. First advantage of using spectral imaging is that you can actually reconstruct different energy levels so that you could improve the attenuation profile of different materials. Look at the attenuation profile of the iodine. The attenuation is highest when you reduce the energies of the photons. So if you are able to reconstruct a monoenergetic level very close to, for example, 50 keV, then you will improve the contrast within your image because you will improve the attenuation linked to the iodine within your image. First input or first benefit of using spectral imaging. The second point is that if you want to analyze an unknown tissue, which is here in the dashed line here, and if you want to analyze its composition based on the relative presence of either iodine or water within that component, well, you can do that with spectral imaging, because if you know the attenuation profile of iodine and water, which of course you do, then you can probably within the system say that the nature of that dashed line is a composition of the red and of the blue line, and you will be able to make a material decomposition where you can actually extract the relative concentration of iodine over water within any point of the image. And that's the second benefit of the system, is that you can shift from a Hounsfield unit map based on attenuation to a density map, atomic density map, so that's the relative concentration of one tissue over another. And of course, dealing with oncology, the relative concentration of iodine over that of water. So now to move on in clinical practice, now that we've understood the principles, the physical principles of this system, you make a spectral imaging acquisition, and then you can reconstruct from those single acquisition different sets of images. The first one is, of course, the virtual monochromatic images based on all energy levels from 40 keV to 140 keV. And the lower you go in the keV, the higher the contrast you will have between the regions with iodine enhancement and those without. The second set of images is material decomposition images, and dealing with oncology, of course, the iodine over water map is very attractive because you will find that you will be able to make the measurements of the concentration of iodine within any element of the images. And that's the way we are going to see how in clinical practice you can use spectral imaging, especially in oncology, for detection and characterization of lesions. So let's move on. How to put that in clinical practice? Well, we have to show it's easy, and we'll see how it is easy to put in clinical practice. The second thing is it has to integrate with our usual workflow. There's no way we can deal with 40 patients a day and having different workflows whether we use spectral imaging or not. So we have to have exactly the same workflow that we used to have in polychromatic images. And of course, last but not least, it has to have a clinical benefit, because there's no use in making any innovation if there's no clinical benefit of dealing with those innovations. And with that in mind, How does spectral imaging kicks into that? Well, actually by two ways. The two benefits of having the improved contrast and enhancement detection. And that's a key issue in oncology because you want to see lesions that enhance. So if you have a system that provides a large enhancement of the lesion, whether because you use virtual monochromatic images with low KAV levels, or whether you use iodine over water maps, then you gain the potentiality to detect new nodules. And we will see in clinical practice how that actually is indeed true. The second thing is, well, if you are able to decompose a material with iodine and water, well, actually you can get rid of that iodine with a reconstruction. And if you get rid of that iodine, actually you could reconstruct a virtual non-contrast image based on an acquisition made spontaneously with contrast or directly with contrast. And if you get rid of that non-contrast phase when it's needed, well, then you reduce the dose to the patients. Second benefit or potential benefit of spectral imaging. And of course, there was two questions with that. First, what's the temporal resolution of the acquisitions? What I mean by that, if you're going to image regions at two different energy levels, what's the actual difference in temporal acquisitions between the first acquisition based on the low energy level and the high energy level? Now that's a key issue. And if you wonder what's the best system with spectral imaging, well, that's a key question you should ask yourself. What's the temporal difference between the two energy levels acquisitions that you're going to make? The second thing is, if you're going to integrate that in the workflow, well, what's the field of view where it's actually possible to make spectral imaging? We're dealing with patients with large body habitus. And if we're dealing with patients with oncology, we have to make thorax, abdomen, pelvis acquisition, even in relatively large patients. That means that the field of view has to be pretty much standard in spectral imaging, and there has to be no limit in the field of view. And with that in mind, then we can move on to actually clinical practice. And I was going to illustrate those different benefits and first focus on the benefits of contrast and enhancement detection. And if you look at that first slide, which is an arterial phase spectral imaging acquisition, a late arterial phase, in a patient looking for hepatocellular carcinoma in a 56-year-old patient, here I provide 3 different sets of reconstruction that are all derived from the same spectral acquisition. So one acquisition, multiple reconstructions that are possible, that you can actually program directly in the acquisition system. And here's just to illustrate 3 different energy levels, 120 kV, 80 kV, 60 kV. And I insist, these are reconstruction images. They are in coronal planes. You can put that in actually transverse, coronal, sagittal planes. You can do whatever you want with the images, exactly the way you would with standard polychromatic images. But if you look now at the contrast within those images, again derived from the same acquisition, and you compare the 60 kV with the 120 kV, there you go with the optimized contrast. Now look at the arterial phase showing how you can gain contrast within an artery here, within the hepatic artery here, that you can actually very much better see here than on the 120 kV. So yes, you can use spectral imaging to improve contrast based on low energy reconstructions, low KAV reconstructions. Second example. Another example also in clinical practice. This is a 55-year-old patient, abdominal pain left lower quadrant. The patient mentions blood in the stools, and this is a directly injected standard spectral imaging acquisition, again with direct IV injection. And in that setting, here's a comparison of the polychromatic spectra coming up from the system and the reconstructed monochromatic energy levels set at 60 kV. So again, a low kV level, and you want to optimize the contrast. And if you look at that image, well, of course, most of you will have detected that lesion here. That small lesion at the left portion of the sigmoid colon, and that image is a sigmoid colon tumor that enhances and that you can actually depict far better on the low KAV levels. Why? Because there's more iodine in that. And that's why you can see the enhancement profile much better when you reduce the energy level of the reconstruction. And that's clinical practice. That's everyday practice. Third example, detecting hypervascular tumors within the liver. Here's a 39-year-old patient. And that patient was followed up after a hepatectomy with a very high risk of HCC recurrence. A patient had been treated with a rescue surgery, with a very large HCC in the healthy liver, with pole vein macrovascular invasion. So this patient is at very high risk for early relapse. And that's the 2 months follow-up CT scan, and that's the images provided by the polychromatic spectra of images. What do you see? Well, maybe you can see a faint enhancement in the left lobe of the liver here. Okay, maybe you can see that. Maybe you can see some washout here in the middle of the lesion. And that washout you can see in the delayed phase. Okay, that's probably a relapse. But maybe most of you are not confident with that. So how could we optimize the images? Well, first thing is, well, let's go for MRI. And if you look at the MRI here that's performed, of course you can see more thoroughly that enhancement, that early enhancement of a lesion, which is actually in restricted diffusion on that diffusion high B value map. Okay, so probably there's HCC relapse. But could you have done better with the CT scan? Yes, you could with spectral imaging. And you could with either low KV reconstructions or using here the iodine over water map. And that map is not a density or an attenuation map. That map is actually a map showing the relative concentration of iodine within any voxel of the lesion. And what that shows is that you have the lesion with high concentration of iodine here in the left lobe, and that lesion is actually a relapsing HCC. So again, optimizing contrast, whether with low KV or with optimized iodine over water maps, that's the way to go if you want to optimize contrast. If we leave oncology for a second and we dealing with a very large clinical practice setting, which is a patient with occlusion, this is a 56-year-old patient. And I'm going to show here the advantages of doing a direct injection with spectral imaging to get rid of the non-enhanced phase. And why do you use the non-enhanced phase? Well, if you read the recent literature and that very nice paper from Martin's team here in St. Joseph Hospital in Paris, now we know that to optimize the sensitivity of small bowel wall detection of ischemia within the bowel wall, we have to use that non-enhanced phase. Why is that? Because in case of venous ischemia of the bowel wall, especially in patients with bowel occlusion, you have that high density within the bowel wall. And if you inject directly with IV contrast, then you miss that hyperdense segment within the bowel wall, and you lose the confidence in the way you're either seeing the enhancement of the bowel wall or you're seeing a spontaneously hyperdense bowel wall, which is actually suffering from bowel wall ischemia. So with spectral imaging, the idea is that with a single phase injected directly, you can get rid and still benefit from the non-enhanced phase. And here how it works. This is provided from the same acquisition. This is the virtual non-contrast unenhanced phase, which is reconstructed from that phase. Again, using the same principles of material decomposition, getting rid of the iodine within the images, and making sure that here, what you do see which is enhancing is not a spontaneously hyperdense bowel wall, but it's actually enhancement within the bowel wall. So, with that, you can get rid with confidence of the non-contrast phase and actually demonstrate that you can reduce the exposition to X-ray exposure in those patients in whom you absolutely need a non-contrast phase for optimized management of the patient. Okay, so this is the last set of images that you can derive from that, which is the iodine map, which provides similar information to the monogenetic low KV levels, because you can actually measure the concentration of iodine within the bowel wall, compare it to normal bowel wall, and make sure that you have a confidence that that patient, although he has hernia, and which of course explains the bowel wall occlusion, there is no bowel wall suffering, and maybe you can reduce the hernia and not get directly to the surgical ward. So when you see that, of course, you say, okay, that seems too easy. I'm not sure, maybe there's a trick. So let's see what tricks there could be. And of course, first trick there could be is, okay, you can do spectral imaging, but you have to change your workflow. You have to change your habits. Well, if you want to put that in clinical practice, you have to make sure that the spectral imaging setup is actually exactly similar, whether for workflow in acquisition protocols and workflow for the way you read images. So of course you can use different systems to make spectral imaging. You can use system with dual tubes, but the question is, do you have the same field of view? And here's an example from the literature showing maybe in certain situations with patients with large habitus, how you should cope with small or reduced field of view in those systems, especially those with dual tubes, where you have to reduce the field of view and put a patient in certain conditions so that it actually fits in clinical practice. So the clinical informations are probably the same, but the way you have to organize your workflow is different. And of course, the workflow has to be similar for radiologists. That is that you have to be very, you have to have the images in an easy way, easy fashion, and you have to make your reconstructions available every day in clinical practice. And that's what we are going to illustrate in the coming moments in different clinical conditions so that we can show exactly how you can put that in clinical practice. So in that kind of workshop, maybe I could illustrate some indications for liver GSI and how to deal with image reconstructions and how to organize the workflow. And this is just a proposal. My proposal for organizing a workflow in GSI technology and spectral technology is first, how you can optimize contrast. Second, how you can use material decomposition and how you can even analyze the attenuation curves to decompose the materials. So on to some examples now. And first one is optimizing contrast and especially enhancement for hypervascular lesions. Now I will take an example of a patient who is screened for HCC. And of course, in HCC, what you want to look for is hypervascular lesions, that is, lesions who will probably gain contrast. Whether if you reduce the monogenetic energy levels where you reconstruct the images, or whether you use material decomposition based on iodine maps, and those are lesions which probably will show a higher concentration of iodine. So let's go and see how it works. So, using low KV level, defining optimal KV level, and showing that on a viewer, that's the way it's going to work now. And here's an example of that patient looking for HCC, and I will show you successively different energy level reconstructions obtained from the same acquisition. Again, it's not different acquisition, it's the same acquisition reconstructed at different energy levels. So here's the 100 KV level. And here's onto the movie. I hope it shows. And there it will stop. Now this is a 100 kV level. That's probably a level where you have a higher contrast, a lower contrast, I mean, as the one you are used to in a clinical polychromatic 120 kVp setting. So this is the late arterial phase, reconstructed 100 kV, where you have probably lower contrast. And I'm not sure if you saw, but there was in the lower portion of the segment 6, a very faintly enhancing lesion, which of course is suspicious for HCC, but you have to be very confident that that is actually an HCC lesion. So maybe using the same acquisition and using just the shift with the mouse button at your station, you can just shift energy level and go a little bit lower. And of course go to 70 kV. Now 70 kV is a very important kV setting. It's probably the one closest to the usual contrast that you have, what you are used to in a polychromatic 120 kVp CD system with polychromatic images. Now again, the image is going now, and you can see a little bit better, of course, improved contrast. A late arterial phase showing the enhancement of a maybe 2 cm or 3 cm large nodule in segment 6. Okay, so you improve the contrast, but maybe you can get even lower. Maybe you can reduce the energy level, and why not go to 50 kV? Now, if you move to 50 kV, of course, you optimize your contrast. And if you optimize your contrast, now that lesion should just be right visible, right in the middle of the images. And let's see how it works out. Launching the images, and I think I have the images a little bit later than you have, so probably you've already seen the images, but this is different contrast. We are still in Kuhn field units maps. This is still a virtual monochromatic energy level, and there you have seen segment 6 lesion. You can see it so much better with low energy levels. So you've improved the contrast. Now maybe you could go differently if you want to optimize the contrast. Maybe you want to reconstruct with a different approach and leave the density map and go maybe with okay, let's see how it shows up with the iodine concentration or the relative iodine concentration within that same lesion. So now we are shifting again the paradigm. We are no more looking at images which are Hunsfeld unit maps. We're looking at images which actually show the relative concentration of iodine within the images that we can see. Again, the same patient, looking at a new way of seeing those images. Now you will see the contrast changes, and the way the images look, they changes. And you can recognize that this is not what you're used to in clinical practice. This is not usual images. But those are images reconstructed again from the same acquisition. So with one acquisition, that's the different images that you can program to be reconstructed, showing the enhancement of that lesion, but seen in the relative concentration map of iodine within that lesion. Again, same acquisition, different reconstructions. And you can program the system to make all the reconstructions you want directly from the acquisition setup, so that you can launch them to the PACS system, and that you don't even have to use any different software. You just use your PACS system the way you're used to, or use your server the way you're used to, and analyze the images you want to reconstruct. So you could maybe reconstruct a low KAV images, set of images, iodine over water concentration map images, and maybe use the polychromatic images to just check that you had the entire acquisition made, and that all the acquisition was actually done. Now, does it work also for hypovascular lesion? Well, actually it does. If you think of that, you're not going to look at the positive contrast of the lesion, but of the negative contrast. That is, what you want to gain is the improved contrast of liver over lesion, but in that setting now, you want to optimize the contrast of the liver. You want to enhance the liver so that the hypovascular lesions will stick out as hypovascular spots within the lesion. Again, in clinical practice, different approaches. One way to go is to reduce the KAV. Again, starting up from the 100 KAV images. So this is, again, a reduced contrast situation as what you're used to in the polychromatic 120 kVp usual setting of abdominal imaging in adult patients. Now you have a reduced contrast here, and you can see the images. First message, of course you can use spectral imaging to make thorax, abdomen, and pelvis acquisition. I mentioned you have to have a similar workflow as the way you are used to in clinical practice, and that's the demonstration. You must use spectral images where you want to use it. If it's thorax, abdomen, pelvis in oncology situation, and definitely oncology situations, you have to make whole body acquisitions, well, there you can. Second thing is, if you use high energy levels, you reduce the contrast. That's maybe not the best option if you want to look for hypovascular lesions within your liver. So how can you optimize contrast? Again, reducing the KAV levels, the energy levels of the images that you reconstruct. And if you see the movie here that's going to be launched at the 50 KAV level, well, there you go. You will see an improved contrast of lesion over background liver, because you have an increased enhancement of the liver and a reduced density of those lesions which are fibrous lesions which do not enhance on the pole phase. Again, thorax, abdomen, pelvis, optimize contrast within the vessels now with low KAV levels. Now look at the way the aorta sticks out here as compared to the 100 kV level that we just saw the minutes before. And of course, you're going to see in the liver optimized detection of the hypovascular lesions, because the liver enhances so much better. You can see the lesions sticking out, and even a very small lesion here, close to segment 5 and segment 6 here, subcentimetric, subcapsular lesions, those lesions which are difficult to see, well, you can see because there's improved contrast. So definitely one way to optimize your contrast, making virtual reconstructions at low KV levels, and making sure you have optimized your contrast. Look at the way also lesions, even close to the gallbladder here, they enhance, and go to the close to the bladder, they enhance, because that was hypervascular lesion, and you gain contrast even in the hypervascular lesions. Okay, we saw how it's maybe easier to see lesions. Now, can we detect more lesions? Now, based on our experience and reviewing the comparison between CT and MRI, we do not detect more lesions in a large cohort of patients that we saw looking for HCC patients. But definitely, it's easier to see, and we have some examples where definitely the lesions were seen at spectral CT and were very difficult to detect, even at liver MRI. And I will illustrate that with one example in the next slide. Now, here's a slide of a patient with liver cirrhosis and chronic hepatitis B virus. Now, those patients, they have a lot of nodules within the liver. And some nodules are hyperdense. Some nodules are hyperintense on T1 weighted images. And those nodules are difficult to characterize because those nodules, you're going to look for enhancement of the lesions, but the lesions are already dense. They're already hyper signal intensity on T1. So how can you detect contrast enhancement? Well, you can detect contrast enhancement if you're able to reduce the energy levels and that you're able to demonstrate that you have iodine within your tumors. And in this patient, there were clearly two small sub-centimetric LIRADS4 lesions that were clearly hyper-enhancing on the virtual reconstructed low energy level, and this is the 50 keV level, where you can see those lesions. Those lesions, they did have washout. They were indeed HCC lesions, but look at the MRI. The MRI was desperate, but it didn't show the enhancement of those lesions. So we did see those lesions on diffusion-weighted MRI. We probably would have characterized those nodules as LIRADS4 because of the restriction of diffusion, but there's no way we could have demonstrated that those lesions did enhance on arterial phase. Again, this is only one example, and in large cohort of patients, we do not see more nodules using spectral imaging. But we have a workflow where we have user-friendliness, we can see the nodules more easily, and in some situations, it's even easier than on MR to detect those hyper-enhancing nodules. Okay, but there must be some drawback. Yes, there are some drawbacks and there are some questions. First issue is a question of dose. What do we lose in terms of dose exposition in those patients? Well, there is a price to pay in there. And here's a comparison of a thorax, abdomen, pelvis acquisition in an oncologic setting in a patient. Image here with a polychromatic imaging, 120 kVp images, and here monochromatic reconstruction based on spectral imaging acquisition. Now that situation was performed after a non-enhanced phase that you can see here with the dose showing here, and an enhanced thorax, abdomen, and pelvis acquisition. CTDI 9 of that thorax, abdomen, and pelvis acquisition. The same acquisition, thorax, abdomen, pelvis, in spectral imaging is 12. So there is a price to pay in terms of dose. I have to mention those acquisitions were made on an AG750 system where the iterative reconstructions is with AZA. You do not benefit from AZVIR on that platform, and we will have to wait for the Revolution platform to have the GSI technology so that we can benefit of AZVIR. But if you look at the dose exposition on a patient basis, combining the non-enhanced phase with the enhanced phase, well, you can even think that you can reduce dose using spectral imaging, because with that phase, with that single acquisition, remember, you can make a virtual non-enhanced reconstruction and actually benefit from the non-enhanced phase without making the acquisition of the non-enhanced phase. So if you compare the same acquisition, you lose in terms of dose exposition. If you compare the entire patient and you can get rid of a non-enhanced phase which was mandatory, then you can even think that you can reduce dose using spectral imaging. Now on to some questions. First one, how do we actually improve the contrast when dealing with spectral acquisition? Now I have to go back to the very nice paper, Radiology 2011. That was actually a phantom evaluation. So 4 syringes with diluted contrast medium or water imaged at different energy level and imaged with a single spectral acquisition, but at different energy levels. And looking at the contrast to noise ratio measured within all syringes, comparing that of contrast medium to that of the contrast obtained in water divided by the standard deviation of the noise within the images. Now, if we look at the curves, what do we see and what do we interpret from the curves? 3 messages. The first one is the CT attenuation varies according to the energy level on the virtual monochromatic images. Whatever syringes was imaged, all showed different attenuation and attenuation profiles using different energy levels. The lower you go, the higher the attenuation. But if you look at the contrast to noise ratio, what you do see is that you have the improved contrast to noise ratio, but at a specific energy level. And in that experimental setup, the optimized energy level was determined to be around 68 keV. And why is that? Because at that energy level, you had a reduced noise which accounted for the optimized contrast to noise ratio. When you go too low in the keV levels, you have too much noise. Of course, when you go too high, maybe you have the same level of noise, but you reduced the signal. So you have to keep in mind, and that's a very important question that you have to answer before you start using spectral imaging. So that in clinical practice, you should determine the optimal energy level where you can improve the contrast to noise ratio of the actual tumor that you are going to image, which is not always that 68 keV level, which depends here on the experimental setup. And based on our experience, which was a lot dedicated to HCC images, what we did look at is the various contrast to noise ratio across different energy levels of those HCC lesions. 18 patients, the lesions of 16 millimeters in diameter, and what we determined is that the optimal contrast to noise ratio level, in our experience, of HCC image on arterial phase with spectral imaging was 49 keV, where we had the highest CNR of lesion over background liver. And this is to illustrate that same acquisition, different reconstruction of the patient with HCC, and the optimized monochromatic level close to 49 keV here, which shows the highest contrast to noise ratio. Again, an optimized energy level based on the clinical situation. Third question, can we go maybe further with clinical application? Actually, if we can decompose the tissue composition of a tumor based on different energy levels, we can actually distinguish different attenuation profile of different tumors. And that's a recent paper of the behavior of different tumors across different energy levels, showing that the attenuation levels of hepatic hemangioma shows different attenuation curves to that of HCC, to that of metastasis, and to that of cysts. So basically, we could maybe distinguish different tumors based on the attenuation profiles. So if we actually could provide for all images an attenuation curve of a tumor that we're going to look at, well, then we can determine the nature of a tumor. That's work in progress. But based on a tumor analysis in itself, not making the analysis of the nature of the whole tumor, but we can actually show that there are different components in the tumor. And in oncology, that's a very usual presentation of tumors. Actually, in the tumor, well, we can distinguish different portions. Now here we put, in a very large HCC tumors here, we put regions of interest on various regions. We put a region on the aorta, and this is the blue line. So if you look at the way the aorta behaves, now that's the attenuation curve of the aorta. Now if you look at the way the active portion of the tumor, that is the tumor that enhances, behaves, there we have the pink line here, attenuation curve. If we put a region of interest bearing the entire tumor, that's the global tumor, we can see that it doesn't show exactly the same attenuation profile. And of course not, because there's tumor necrosis within that tumor. And probably we have here a hint where we could use spectral imaging to provide a functional analysis of the component of the tumor. And of course the liver behaves also differently because it shows less enhancement on the arterial phase. Maybe we could go even further and make the analysis of different components even in patients undergoing TACE, transarterial chemoembolization. A patient followed up after TACE, and again different regions of interest are placed in that patient. We put a region of interest directly in the lipidol, that's the pink line, and look at the attenuation profile of the lipidol. That's definitely different from that of active lesions. That's the yellow region of interest here, residual enhancement within the tumors. And again, that's different from the adjacent liver, which shows a distinct attenuation profile. And you can use that different attenuation profile. You can extract the attenuation profile. You have to use the GSI viewer for that. You cannot use a PAC system. So this is a little bit going further with the analysis, but you can do that with standard acquisition of spectral imaging. So you could actually think maybe you could distinguish lipidol from arterial phase hyperenhancement. It's not always straightforward, I must admit, especially when the lipidol is entangled with the arterial phase enhancement. So there's work in progress as well, but there's a way to deal with the actual analysis of the tumor components. Last slide, and that's maybe the strongest work in progress to be achieved. That's a very interesting paper, very recent paper, comparing the actual Hughes field units observed in virtual unenhanced images versus the true non-contrast images obtained in polychromatic imaging. And what that study shows in 94 patients is that there's actual fluctuation, close to 10% of fluctuation in the actual Hughes field units that you can measure on the virtual unenhanced images reconstructed from an IV injected spectral images. What that means is that you shouldn't be using the virtual unenhanced images for measuring the Hughes field units if what you are measuring is in that level of uncertainty, of that 10% uncertainty. That's the first message. The second message is, well, we have to work on that to improve the virtual non-enhanced reconstructions. Remember, because it's a reconstructions, if we can improve the algorithm, providing that virtual non-enhanced view, we will improve the way those images look. And remember the image I showed of the occlusion, they were actually distinct with something different from those that you could see in clinical practice. So to wrap that up, dual NGCD is very interesting for tissular characterization. I tried to demonstrate that you can use that in clinical practice with routine workflow, routine application. You can optimize, of course, the use of contrast agent enhancement. You can use material decomposition, and that could be very important, especially in the functional analysis of oncology. And that's maybe a potential role in quantitative functional imaging. And of course, ongoing improvements that are still necessary, especially for the virtual non-contrast images. And last improvement, of course, is reducing dose, because you still have increasing dose when you compare actually the same acquisition of spectral images and the polychromatic standard images. And with that, I finished my presentation, and I would definitely love to hear from you and to have feedback from the questions. And I will open the feedback and see what questions have already popped up. Okay, let's see the questions coming up. Okay, first question is, can you use spectral imaging using the same temporal resolution as you used in polychromatic images? Well, actually, that's correct. One way to answer that is, what is the timing of the acquisition? Well, the timing of the acquisition is based on the rotation speed and the pitch. So if your system, which is the case with the HD750, is able to compute a 0.6 second rotation per for every rotation, and you can have the same pitch that you use Well, there you go. You can have exactly the same temporal resolution. But that's a very important question, because if you want to use that in multi-phase acquisition, you must make sure that you have the arterial phase and the polar venous phase in very strict definition of timing, and that's the case with spectral imaging. I've got a question here showing, shouldn't iodine water maps illustrate only iodine? Shouldn't bone structures be suppressed in iodine over water map images? Well, do remember this is not actually a reconstruction based on the actual Hounsfield unit. It's based on the behavior of those lesions that do have different atomic numbers. So, of course, you will have a decrease in the way the bone is represented, but this is not iodine. So, actually, the iodine will show differently on the iodine over water maps. And you can, of course, use different maps. You can use bone over water maps if you want to improve the way you can see the bony structures. We do not have exactly the same atomic numbers. A question here, can we reduce just to one phase deacquisition? My understanding, of course, is that the question is, could we just rule out totally the non-enhanced phase? My answer is yes, if you do not need to measure specifically a Hounsfield unit number, where you must be very strict in the way that you can analyze that Hounsfield number. So, for instance, for adrenal glands evaluation in CT, my answer would still be cautious. Be cautious, because if you want to use the virtual non-contrast images to have a true Hounsfield unit measurement, do remember this 10% filtration. But if you are in a clinical situation, like for instance patients with occlusion or patients with oncology follow-up, of course you can do direct IV injection, because what you're going to look for is the actual difference between non-enhanced, virtual non-enhanced phase with injected phase in terms of the contrast that you will be able to see. Okay, I have a question. Do you reduce the amount of contrast agent in GSI imaging? That's a very important question. Of course, probably what you mean is if you can improve the contrast, well then you don't need to use that much contrast agent, because you will gain with the system with spectral imaging what you lost by using a lower quantification, a lower quantity of iodine. That's probably true for everything which uses arterial phase images. That's probably true in a lot of oncology situations. But again, some words of caution. When you're dealing specifically with liver imaging, what you're going to look for is not only the arterial phase enhancement, but also the interstitial dispersion of the contrast agent within the liver or within the tumor interstitium. And in that setting, you have to have a large amount of iodine that's available even in the delayed phase. And I still have a question here. If we reduce the quantity of iodine that we inject, the arterial phase will be very good. The polar venous phase will be good. But probably the delayed phase, well, maybe you could miss things. And I must admit, I do not have an experience of doing GSI on delayed 3 minutes imaging of HEC. What we did was doing GSI on the late arterial phase and the polar venous phase. So again, well, we have to work, and we have to work together to improve the way we use spectral imaging. Okay. Any more questions coming up from the audience? Well, if there's no more question, again, I would like to thank you all for attending that session. Very happy that, and I hope that technically everything was okay for you, for everybody here. And I hope to see from you in a further webinar, maybe with sharing experience with GSI technology. Again, thank you again, and bye-bye to all. Bye-bye.